Thank you very much, Ingeborg, for the introduction. And I hope you've enjoyed today as much as I have. I mean, it's just been a fantastic day with so many different topics and of AI, surgery. I've learned a lot. So congratulations to Heidelberg for organizing this. So I've been asked to speak about modern glaucoma procedures, but I want to start by saying that I agree with Norbert and Esther that trabeculectomy is the best glaucoma surgery. It's the best of the bunch because it's the most powerful. So what I'm going to talk about, I don't think they're going to replace trabeculectomy. I think they just give us other treatment options. And the EGS has produced this helpful guide on innovative surgeries for glaucoma. And that and the new EGS guidelines have sort of categorized glaucoma surgery into these sort of three broad groups. So we have the traditional bleb forming surgeries on the left, and then the moderately invasive bleb surgeries in the middle. And it's arguable, if you create a bleb, that comes with bleb-related risks. So it's not minimally invasive, but perhaps moderately. And then we have the minimally invasive glaucoma surgeries on the right, of which there are several. So I thought it would be useful to perhaps just briefly outline some of these for those of you that aren't familiar. But basically, MIGS, this is the definition in the EGS guidelines. It's a procedure that entails less tissue manipulation with the expectation of a better safety profile and quicker recovery compared to conventional filtration surgery. And MIGS procedures are typically combined with cataract surgery. They have a sort of synergistic effect, and the cataract operation on its own can have quite a large proportion of that in some. And there's a modest reduction in pressure compared to bleb forming procedures. So if we start by looking at the trabecular bypass procedures, I think this is quite an attractive proposition because the pathology of glaucoma involves increased resistance through the trabecular outflow. So if we could bypass that, that could lower pressure. And this study from 1963 looked at what happens if you do a 360-degree trabeculotomy. And they found that the trabecular meshwork and the inner wall of the Schlemm's canal account for more than 75% of outflow resistance. So it makes sense to target this route. Now, the first of these devices was the iStent, which is a small titanium implant that passes through the trabecular meshwork. And this has gone through several iterations. So the first was the iStent G1, which was like a snorkel-shaped device. And then they realized that putting two iStents rather than one might be better. So they had the iStent Inject. And there have been some randomized control trials looking at these prospective controlled trials, but they are sponsored by the manufacturers. But these showed this modest reduction in pressure, but also reductions in medications. And then the iStent W came along. So this is still using two stents, but the only real difference was making the flange larger, because sometimes iStent could be over-implanted, and so that's sort of this large flange that tried to prevent that. And then more recently, we have the iStent Infinite. So we've gone from one iStent to two and now three. So the Infinite refers to the number of clicks you can do, not the infinite number of stents that can be placed in the eye. But this was actually FDA approved to be used in more advanced disease and even in people who've had failed surgery, which I think is not the sort of typical indication for MIGS. So that's the iStent. Then the other device that we have is the Hydrus. Now, the Hydrus has the same idea of bypassing the trabecular meshwork, but it also tries to scaffold open Schlemm's canal and provide access to a greater number of collector channels. So it's quite a large device. It's 8 millimeters long, and it's made of an alloy of nickel and titanium. So the iStent and the Hydrus are the only two of the MIGS devices that have prospective randomized control trials. And the main study for Hydrus is the Horizon study, which was again sponsored by the company that manufactured the device. And this now has follow-up up to 5 years. But so we can compare to iStent, the 2-year results, the primary endpoint is a 20% or more reduction in intraocular pressure, and that was achieved for 77% of people who had a phaco Hydrus. But look, almost 60% of people that had a phaco alone achieved that too. And compared to iStent, it was 75.8. And then the change in absolute pressure, the difference between a phaco plus a phaco Hydrus was only 2.3 millimeters of mercury on average. And it was 1.6 for iStent. And one of the endpoints that MIGS studies look at is the reduction in medication and patients being free of medications. And that was quite impressive, but also even for cataract surgery alone. So 46% of people who had a phaco were actually off medications 5 years later. Perhaps not real world experience. But I think something that's interesting is more sort of patient-centered endpoints. And so the studies have started in post hoc analyses to look at visual field progression and also the subsequent need for further surgery. And there's some early evidence that a phacohydrous, phaco-MIGS might slow visual field progression, but this is all we have, just post hoc analyses. So a newer procedure, which again tries to bypass the trabecular meshwork, uses a laser to do the same. So this is effectively an eye stent times 10. You do 10 laser holes. Whether these holes stay patent, we don't really know. But there is an ongoing randomized control trial comparing phaco excimer laser trabeculoplasty versus phaco eye stent, which we're involved in. So they're the trabecular bypass type procedures. And then we have some procedures that try to cannulate Schlemm's canal and open up Schlemm's canal, ab interno. So this is an ab interno canaloplasty procedure using the eye track. So you can hopefully see this sort of flashing light, which is the tip of a catheter that's being passed through Schlemm's canal, and it deposits viscoelastic in the canal. And then you can choose to either just perform a canaloplasty with a viscoelastic, which is perhaps less destructive, or to pull through and do a goniotomy and sort of tear the roof off Schlemm's canal. And there's cheaper ways to do this. You don't need to necessarily have quite expensive devices. So this GATT procedure just uses a Prolene suture to perform a 360-degree trabeculotomy. And then the Cahoot dual blade, I always think of it as a bit like an ice cream scoop, sort of scooping off the trabecular meshwork basically performing a trabeculotomy. And there's a cheap way to do this as well, just to have a needle, bend the tip of the needle, and you have the bang procedure. So the bang procedure and GATT are much more common in sort of middle income countries, in income settings where they don't have the reimbursement for the more expensive devices. So that we've covered the trabecular and Schlemm's canal-based MIGS, then we have the suprachoroidal MIGS. And I think the suprachoroidal space is quite an interesting space because it has the potential to lower pressure more than just bypassing the trabecular meshwork. Because, of course, we have the episcleral venous pressure, which gives us a safety net. We're not going to get hypotony, we're not going to have to do transconjunctival sutures if we've done a MIGS device, but unless we have a complication like a cleft. But with the suprachoroidal procedures, you can get lower pressure. And we know that the uveoscleral outflow in the normal eye is important. It accounts for a high proportion of outflow in glaucoma when the trabecular meshwork and the conventional pathways become diseased. And it decreases with age. And we also see in people who have injuries and develop a cleft, you can get very low pressure. Now, there was, of course, a device, the CyPass, which made use of this space, opening up the suprachoroidal space. But this was withdrawn because of safety concerns. It affected the corneal endothelium. So although MIGS are claimed to be safe, we have to be aware that they're not without risk. And sometimes long-term surprises can happen. There is one commercially available suprachoroidal device, ab interno choroidal device called the Miniject. And this is like a honeycomb, sort of sponge-like material made of silicon. Most of it is just empty space. It has this sort of green ring on which indicates the depth. So here's a video of the device just being inserted there into suprachoroidal space. And it's quite a vascular area. There's a high potential for bleeding in this area. So I'm not sure, this definitely isn't as minimally invasive as some of the other MIGS. And then here's something that's definitely not minimally invasive, but this is something called Intersil, which is a uveal spacer. So this is obviously ab externo, but you basically make two large scleral incisions down to the uvea and then pass this sort of skewer across the uveal space and then grasp the device. I'll just go back so you, just in case you missed it at the beginning there. But you can see in the left hand, there's this clear spacer being sort of pushed and pulled into the uveal space. So this is something which actually is now CE marked, doesn't really have much data at the moment. So it's blebless. You don't get a bleb, but it's definitely not MIGS. So what are the pearls we can take from the EGS guidelines related to MIGS? Well, we shouldn't consider them without risk and without cost. We shouldn't use MIGS in those rapidly progressive patients, so the fast progressors, and they're not indicated for people with advanced glaucoma or those that need low target pressure or in angle closure too. Now, I was going to talk a little bit about moderately invasive bleb surgery as well, but we've covered quite a bit about that because that mainly relates to the PreserFlow. And I'm not sure that is such a newer procedure now. But the PreserFlow should offer us greater safety than some of the sort of large tube and plate devices. And it should, in theory, offer greater safety than a trabeculectomy because it's designed so it has intrinsic flow resistance. The lumen and the length are designed so that, in theory, you shouldn't have hypotony. And then, of course, the trade-off with that is that we can see from the study not achieving as low a pressure as trabeculectomy. I think you've seen a video of that already. So we know that the PreserFlow tends to fail because of the pressure not being low enough, whereas trabeculectomy tends to fail because of the safety issues. But I wanted just to highlight that PreserFlow also has those risks. It's a bleb forming procedure. So when you look at the sort of complications of a shallow anterior chamber, 6.8% with PreserFlow, 8.4% with TRABs, hypotony maculopathy, still 0.5% of PreserFlows had that, and almost 5% of PreserFlows had choroidal effusions. So it's not achieving quite as low a pressure. It is slightly safer in this study, but problems do still happen. One thing you can do with a PreserFlow to try and improve the safety is you can put sort of an intraluminal stent suture down. So you can use a small nylon suture in those higher risk people, or perhaps in everyone, where you want to try and restrict flow and reduce that risk of hypotony. But I think sort of what we're really aiming for is a better way to get the balance right, to get good pressure control, avoid the pressure going too low. And there are innovations like this, the Calibri, which it has 3 channels, and the channels can be open or closed using a laser. So if the pressure's too low, you can laser and close a channel. So it's basically titratable pressure lowering. So I think things like this are very interesting. At the moment, there is a device called the iWatch, which has a magnet and a little sort of valve almost that you can open and close using a magnet, but that's very large, very bulky. But I think that's the future. So in terms of minimally invasive bleb surgery pearls from the guidelines, trabeculectomy appears to still be more effective in terms of pressure reduction and seems to have a low risk of failure. We need to think about the proper positioning to protect the endothelium. Now, we're at a Heidelberg meeting, and you might be thinking, well, I haven't spoken about OCT, I haven't spoken about imaging. So I thought it's important that we do that. So what about imaging? Now, stents are not always put in the right place. So this is an iStent generation 1, and you don't have to be that good at gonioscopy to know that's not in the right place. And that's not infrequent, unfortunately. So there was a study where they used OCT to look at the position of iStents. 72% were not positioned within Schlemm's canal. This wasn't in my clinic, I have to say. Well, I'm not sure where it was. But, and even if you position it, though, in the right place, if it's in the Schlemm's canal, one of the problems is that the flow within Schlemm's canal is not continuous. It's segmental. And it doesn't guarantee that you're going to get access to a collector channel too. So there are issues. Now, what can we do? Well, we can use Vision Blue to stain the trabecular meshwork. So during surgery, that can give us better visualization if we're not sure where the trabecular meshwork is. And then once the stent's in position, we get some feedback because we can see blood reflux. So you can say, well, that's probably in Schlemm's canal. That looks like a good position. But the problem is we've already done it. We've already put in the device. And we can do other things. So we can put in Trypan Blue, and we can see blanching of the vessels. We can see sort of the blue flushing through the episcleral vasculature. So, I mean, that's really satisfying to see, but it's too late. So what might we do in the future? Well, we could also use OCT intraoperatively, and that's, again, a nice toy. it might show us where the stent is, but maybe in the future we'll be able to use interoperative OCT to actually target where we're putting things more accurately as the OCT becomes better. Now, Alex Wang at UCSD in San Diego has, in collaboration actually with Heidelberg, looked at aqueous angiography. And in this, they put ICG into the anterior chamber, and then using the OCT Flex, this OCT that can do intraoperative OCT, they can measure they get these lovely images, really, angiography of the outflow system. But this creates some problems because we still don't know what do we actually target. Do we look for areas of high or low flow? And what if you did aqueous angiography and there's no flow whatsoever? Maybe you can't get flow, you can't establish flow. Maybe it's better to do a trabeculectomy. So there's lots of unknowns. And then there's one other technique which is called hemoglobin video imaging. And this uses the hemoglobin absorption spectrum to sort of enhance the contrast between red blood cells and their surroundings. So you can get these nice images of the outflow system. But this is all really at its infancy. And at the moment, we're kind of treating with these MIGS devices a little bit blindly. So we have a wide range of options. I think, though, we need to be careful. And the Royal College of Surgeons in England have made these recommendations about surgical innovation. And there's a paragraph which I really liked. It says, exciting as these innovations are in terms of their potential, there are significant risks. And that word exciting, new things are exciting. They're exciting for surgeons, exciting for patients, but it doesn't necessarily mean they're better than what we already have. And that's something called enthusiasm bias. We need to be careful about that enthusiasm bias. And remember that newer doesn't always equal better. So thank you very much.